Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a totally unedited recording of phacoemulsification of a mature white cataract. Let us observe this surgery. This is the main incision on the posterior aspect of the limbus with a 2.8 millimeter steel keratome. And this is a side port on the right side of the main incision, and this is another side port on the left side of the main incision. And now an air bubble is injected into the anterior chamber, and then trypan blue dye is applied over the anterior capsule beneath this air bubble. Now the dye is washed out with BSS. The pupil has dilated very well in this case. When the pupil dilates very well, we have to be careful in making the rhexis. There can be a tendency to do a large rhexis, but we must not do that. We must do optimum sized rhexis. The anticapsule is incised and a capsular tag is raised. Now I use a utrata forceps, hold this capsular tag, go anticlockwise and do an optimum sized rhexis. Size of this rhexis is about 5.5 to 6 millimeter. And now hydrodissection. This is a non-intumescent cataract, so little bit of hydro is being done. The nucleus is tapped. I didn't rotate the nucleus because I know that it will rotate when I start chopping this nuclear fragment. There was some chemosis. I moved this chemosis to the nasal side, and now the tip of the phaco needle is introduced. Bevel down, some superficial cortical lens matter is removed. Now the handpiece is turned, bevel is up towards the cornea now. This is the easy tip of Ocular. The machine being used is Pharos. And here it is. This is the first job. The tip is buried into the substance of the nucleus. The nucleus is held very firmly and then it is chopped. So whenever you attempt chopping, go into the substance of the nucleus, come back to aspiration, that is vacuum, hold the piece very firmly with vacuum and then chop it. Ultrasonic energy used in this case is 60%, flow rate is 45 ml per minute, vacuum is 450 millimeter of mercury. This is Pharos from Otley, Switzerland. This is the last nuclear fragment. At this time we must take care of the stability of the anterior chamber. Yes, the nucleus is managed. Epinucleus also has come out, and now cortical cleanup is to be done. Visco 2% SPMC is applied into the anterior chamber and the capsular bag. And now a 23 gauge Simcoe cannula is being used to clean the cortex. This is a very safe instrument. You can control the vacuum very nicely from 0 to 600 just by using a 10 cc syringe. I use a 10 cc glass syringe and this 23 gauge Simcoe cannula. So this is a very nice instrument for cortical cleanup. So cortex is removed, and now little bit of polishing of the undersurface of the anterior capsular rim. And now hydroimplantation of a single piece monofocal intraocular lens is being done. Since I am using a B cartridge, I enlarge the incision little bit. The size of the wound is about 3 millimeter now. Now hydroimplantation means you keep the anterior chamber formed by irrigation and implant the lens. Viscoelastic substance is not used, so the lot of time is saved. The time we had to devote for cleaning of visco is saved. And now the side ports are to be closed. This is a bit of moxie, and then corneal stroma on either side of the side ports are hydrated. Hydrate the scleral side of the side port. Don't hydrate the corneal side of the side port. If you hydrate the corneal side of the side port, the risk of DMD, that is Descemet's membrane detachment, is more. Now this is final lavage of the anterior chamber. Anterior chamber, the capsular bag is irrigated and aspirated for a few seconds. Then the anterior chamber is formed very nicely, and integrity of all the wounds are checked. There should not be any leakage from any side, and then the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients, the human beings, with lot of love, respect, empathy, and your great surgical competence.